Are we
All right.
ready?
Yep.
Okay.
Good to go.
Okay. Good afternoon. I'm Pat Plecky, former president of the Medical Society of Virginia Foundation and current co-chair of the Next Chapter Committee. Next Chapter was a committee started last year for retired and semi-retired physicians and physician assistants. We've been working on various things for this group of physicians and such as this webinar today. We'll tell you a little bit more about the Next Chapter Committee after we have our speaker. Today's webinar is Patient Advocacy and Needs Navigation. Our speaker is Emily Brown. Emily serves as Patient Education Content and Project Manager for the Patient Advocate Foundation. In this role, she develops new educational materials, including publications, webinars, and special projects, all designed to help patients prevent and address healthcare barriers. Previously, Emily worked as a clinical case manager at PAF, where she specialized in complex cases involving health insurance appeals. She possesses extensive experience in Medicare, medical debt crisis, and long-term care issues, along with comprehensive knowledge of federal, state, and local assistance program. Before joining PAF, Emily gained experience as a social services coordinator in a skilled nursing facility and as a social worker in a PACE setting. She holds a bachelor's degree in social work from Christopher Newport University. In her free time, she enjoys traveling with her husband and being a mom to twin toddlers. Thank you, Emily. And feel free to contact her directly, and she will let you know how to contact her. Thank you. And Emily, it's all yours now.
Thank you so much. I appreciate the introduction. I'll go ahead and get into it and share my slides. All right. So, as mentioned, we're going to be talking today about navigating care systems for aging loved ones, and we'll go over insurance, care options, and advocacy. So I want to start with a brief introduction and history about Patient Advocate Foundation. It was started in 1996 with a volunteer staff of 2 and served 150 patients in its first year. And now, 30 years later, we have a full-time staff of over 240 employees, and we've directly assisted over 2.2 million patients. Our foundation was started by Nancy Davenport Ennis and her husband, Jack, in honor of their dear friend and breast cancer patient, Cheryl Grimmel. They were inspired to advocate for patients after Cheryl experienced hurdle after hurdle trying to access care for her breast cancer in the 90s. And she was halfway through her treatment only to find out that the procedure was not covered. And it was just devastating to them. So Nancy and Jack knew that they didn't want any other patients to go through what Cheryl had been through. And so on the night of her funeral, they wrote the business plan for Patient Advocate Foundation. And now we are the nation's largest comprehensive healthcare safety net charity. So a quick breakdown of our service areas of engagement and kind of how we help patients. So our case management services are the foundation and really the heart of Patient Advocate Foundation's mission. And it continues to be the kind of central activity that underpins all the rest of our programs. We have a team of over 40 case managers who assist patients, caregivers, providers. Our services are provided at no cost to the patient or the point of contact. We serve patients nationally by telephone and email, and the case managers really work one-on-one with patients to resolve their issue as it relates to their diagnosis. So as far as eligibility for that program, patients can have any insurance status. They can be any age, any gender, any ethnicity or cultural heritage, any employment status. They can reside in any state in the US or territory, have any income range, including no income, and they can be diagnosed or screening for a broad range of diseases or diagnoses. So last year alone, we served patients with almost 1,000 different diagnoses. There are 3 main kind of buckets of assistance that we provide through case management. The first being health insurance navigation, and that's really our bread and butter. That's the main reason people reach out to us. But we also assist with disability and workplace navigation, financial hardship, cost of living, and medical debt as well. So our copay relief program assists patients with diagnosis-specific funding to pay for copayments. And for some of our funds, we also assist with medical insurance premiums. Our copay relief program provides direct financial assistance to patients who have insurance, who meet qualifications to help them just pay for their prescriptions and treatments that they need. So essentially, this assistance helps patients afford out-of-pocket costs for medications. And last year, we served 76,000 people and gave out over $208 million in aid. Through our financial aid funds, we administer small grants directly to patients to help them with non-medical expenses like transportation, food, and housing. Those are also diagnosis-based assistance. So these are small grants, usually anywhere from $300 to $1,000 that we can provide directly to the patient to help offset some of those costs. Our education initiatives provide actionable advice and guidance to patients, caregivers, healthcare professionals. We have a range of topics in a variety of formats. We do webinars like this, other interactive trainings, written publications, podcasts, animation, all kinds of good stuff. We also offer a Scholarship for Survivors program that grants scholarships to patients who have been treated for a life-threatening diagnosis in the last 5 years. So we have 2 grants for those, 2 scholarships for undergraduate and graduate students. So just like I said, wanted to provide a little bit of context to who we are. We're Virginia-based, although a lot of people don't know about us. So I just wanted to share a little bit about who we are and what we do before we get into today's topic. So today, this webinar is intended for adult children of aging parents, spouses of aging partners, family caregivers who are encountering new challenges, and any individuals who are planning for future care decisions. Today, we're going to talk about understanding the care continuum and your options, how Medicare and insurance coverage functions across those different settings, practical resources for locating quality care, essential planning for advanced directives, common challenges and strategies to overcome them, some advocacy tips, and I also have some key resource takeaways. We are going to go over a lot today, but this session will be recorded. So I also have some resource handouts that I can distribute. So getting into it, the long-term care landscape. Let's start by throwing out the idea that there's one right answer for aging. The old model for aging was pretty simple. You lived at home until you couldn't, and then you went to a nursing home. But today we have a lot more options, which is wonderful, but it can also feel really overwhelming. And feeling overwhelmed is completely normal. The systems we're going to talk about today were not designed with families in mind. They evolved kind of piecemeal over decades. But there is good news. We can navigate them successfully as long as we have the right information. As well, I want to kind of set the scene and acknowledge that everybody's situation is unique. So, your 85-year-old father with diabetes is going to have wildly different needs than someone else's 67-year-old mother with, onset dementia. So we're just going to walk through the frameworks and tools that you can use to adapt to your specific circumstances. And there's really a key principle to all of this, which is right care at the right time in the right place. So the goal is not to find the perfect solution immediately, because there probably isn't going to be an immediate solution, but really it's to match your loved one's current needs with the appropriate care level, while also thinking about and planning for future changes. So we're going to take a look at starting some of the common settings for this type of care, from kind of least to most intensive. So according to AARP, about 90% of older adults want to stay in their homes as long as they can. And for a lot of people, that is possible with the right support. So aging in place enables seniors and older adults to remain in their homes while receiving that necessary support. It helps preserve independence, dignity, and it also nurtures a connection to their community. It's the most cost-effective option, and like I mentioned, the preferred choice for most older adults. So when we talk about independent living, we're talking about tailored care that scales with the changing needs of patients. So they're able to maintain those familiar routines, their familiar environments, and with support like technology solutions, medical alerts, telehealth, that can definitely be achieved. Aging in place can be facilitated using home health aides, nursing visits. In this case, the patient receives professional medical care delivered at home. Services can range from medication management to wound care, skilled nursing for post-hospital recovery, or chronic conditions, personal care assistance. There's also adult day programs that they provide structured daytime activities and socialization for patients outside the home. That's ideal for a lot of folks because it provides respite for family caregivers while the patient gets to maintain their home-based living. So it's nice because they're offered health monitoring, meals, therapeutic activities. And it also helps to prevent that isolation that we see a lot of older adults facing. There are over 40 million Americans who are providing unpaid care to their aging loved ones. So it's really important to tap into those support services, caregiver training, caregiver counseling, respite care. There are some states that offer, paid family leave, and that's something we'll talk about a little bit later. But just really preventing the caregiver burnout is essential in being able to sustain an aging in place or home-based care situation. And like I mentioned earlier, we need to recognize that aging in place is not going to be suitable for everyone. Folks with advanced dementia or complex medical needs are going to require a higher level of care. So next, let's look at our community-based options. These are sort of the bridge between complete independence and your residential care options. These services are often underutilized because I think a lot of people just don't know they exist. So the first is going to be senior centers and meal programs. These options generally provide nutritious meals, social engagement opportunities to help combat that isolation and that loneliness that we know that sometimes happens in older adulthood. There's often activities, health screenings, educational programs, and they really help maintain that independence while staying connected to the community. Transportation services are available in a lot of communities for medical appointments, grocery shopping, and social activities for folks who can no longer make those trips on their own or, no longer drive. That also helps reduce caregiver burden. You've got reliable, safe transportation. And a lot of programs actually do door-to-door service, so that's really wonderful. Respite care programs give family caregivers temporary relief from caregiving responsibilities. They're available in a lot of different formats, sometimes in-home care, adult day programs, short-term residential stays. They just allow caregivers to attend to their own personal needs, to work, or just to rest while they know that their loved one that they're caring for is getting good care elsewhere. And the last community-based option is PACE. This is the Program of All-Inclusive Care for the Elderly. You may have noticed, if you remember in my introduction, I used to be a social worker at a PACE facility, and I cannot express the value of a program like PACE. It's a comprehensive care model that allows eligible seniors to remain in their homes. It coordinates all medical, social, and long-term care services through an interdisciplinary team. And it is available for folks who are 55 and greater, who are certified nursing home eligible, but can safely live in their community with support. Most of the participants are there are dual eligible, so they're eligible for Medicare and Medicaid, and services are totally free with no cost sharing. So talking a little bit about residential options, the key here is understanding that moving to a care community doesn't mean giving up independence. It means right-sizing your loved one's situation to match their needs. So assisted living is probably the most misunderstood option. Some people think that it's kind of like the step before a nursing home, but really it's designed for people who need some help, but want to maintain their privacy and their independence. So it's just like having your own apartment, but having those services available if and when you need them. Assisted livings provide housing and personalized care and then, help with those daily activities, bathing, dressing, medication management. There's also memory care units available to a lot of folks for individuals with Alzheimer's, dementia, other memory impairments. They're often secure environments to help folks who may wander or elope, just to help reduce confusion. There's staff that are fully trained in dementia care techniques and behavior management. Lastly, we're looking at continuing care retirement communities, or CCRCs. This is a really unique model. It's that continuum of care from independent living through skilled nursing, but it's all on one campus. So this concept really allows patients to transition between care levels as their needs change. Typically, there is an entrance fee plus like a monthly charge, but you have the security of knowing that you have the type of care that you'll need when you'll need it. So it's really nice because it combines independent living amenities with just the assurance of knowing that as your needs change and you need further care, it will be available to you. So lastly, nursing home and skilled care facilities. So nursing homes, I think, get a bad reputation, and frankly, some of it is deserved. But when someone needs 24-hour skilled nursing care, a good nursing facility can be a godsend. And really the key to this is knowing the difference between custodial care and skilled care, because that determines what insurance is going to pay for. So nursing homes, like skilled nursing facilities, provide 24/7 medical care and supervision for folks who have complex medical needs and cannot live independently. Rehab centers deliver intensive short-term therapy services after a surgery, an illness, or an injury. And generally with this type of care, folks are looking to regain function and return home, or to return to a lower level of care. So you're going to be getting a lot of physical therapy, occupational therapy, speech therapy daily, again, with that goal of returning to previous function. And hospice care, whether at home or in a facility, focuses on comfort, quality of life for folks with terminal illness. Like I mentioned, we're here talking about facilities, but hospice can also be provided in the home or in a hospice facility. And all three settings are staffed by licensed healthcare professionals, but Medicare and Medicaid coverage varies depending on the type of facility. Moving on to the elephant in the room is paying for care. An unfortunate hard truth is that Medicare was designed for acute medical care, not long-term care. It covers getting better, not getting older. But understanding what it does cover can really help you plan and also save you money. As you're likely aware, Medicare has 4 parts, but for long-term care, we're mainly concerned with parts A and B. Part A covers hospital and some skilled nursing facility stays. Part B is going to cover your medical services and equipment. For skilled nursing facility stays, Medicare A covers a very limited stay in a skilled nursing facility. So you're looking at up to 100 days, but it must follow a qualifying hospital stay. And if it's for rehabilitative care, like physical therapy after surgery, not for permanent residency. So like for instance, your father breaks his hip, he goes to the hospital for surgery and then he needs rehab. Medicare Part A will cover his hospital stay. He goes to a skilled nursing facility for rehab. Medicare is going to cover the first 20 days of his stay completely. And then if he needs additional care, days 21 to 100 will be a daily copay. Usually it's a couple $100s a day. That copay will change generally annually. But this is the crucial part. Medicare only is going to cover this if there is a skilled need, like physical therapy, wound care. If he just needs help getting dressed because he's really weak after, his fall, that's custodial care, and Medicare will not pay for that. Home health care. Medicare will pay for intermittent skilled nursing or therapy at home, but the patient has to be considered homebound. Again, this is for skilled medical needs, not for a full-time caregiver. Medicare is going to cover home health services, but only under specific conditions. So the patient has to be homebound, needs skilled therapy or nursing, and have a doctor's order. But if those conditions are met, Medicare will cover 100% of approved services. And homebound doesn't necessarily mean bedridden. It means that leaving your home requires considerable effort. So, someone can still go to church on Sundays or get their hair done at the beauty shop every other week and still qualify as homebound. For hospice care, for those who have a terminal illness, Medicare covers hospice care, which again, provided in-home or in a facility 100%. As far as what Medicare does not cover, we talked about that custodial care. Medicare is only covering skilled medical care, not any kind of assistance with ADLs. So if a patient just needs help bathing, dressing, eating, using the bathroom, that is not going to be covered. And that is unfortunately, a really big surprise for a lot of Medicare beneficiaries and their families. They just think that Medicare is going to help them indefinitely, and that is not necessarily the case with long-term care. So like we just discussed, Medicare does cover short-term skilled nursing facility stays, but again, permanent or long-term custodial nursing care not covered. An average nursing home is going to cost anywhere from $6,000 to more than $15,000 a month. That is either out of pocket or through Medicaid, which we will talk about a little later. Room, board, and custodial care at assisted living facilities are your responsibility. Medicare may cover some of those specific medical services provided, but not the housing itself. So generally, and again, these are very general, the monthly cost for an assisted living is going to range from about $3,000 to $7,000, $8,000, $9,000, depending on the location. Adult daycare programs are not considered medical care. They're generally just for respite. So they need to be covered or budgeted separately, and there's no Medicare coverage. Lastly, Medicare does not cover any kind of home modification. So wheelchair ramps, walk-in tubs, grab bars, none of that is covered, even when it's medically necessary. Those kinds of safety improvements are going to be out of pocket. And depending on how extensive we're looking at, I mean, it could cost anywhere from a few bucks to tens of thousands of dollars, depending on what's needed. So at home, Medicare Part A is going to cover your skilled home health visits. We kind of touched on this a little bit, but they will cover nursing care, physical, occupational, or speech therapy. Patient has to be homebound, and then there's no kind of copayment or anything as long as the criteria is met. And it is limited to part-time intermittent care. It is not 24/7 custodial care. Medicare Part B is going to cover medical equipment and services. So it covers DME like wheelchairs, walkers, hospital beds, oxygen, certain preventative services, diagnostic tests that can be performed at home. And that is covered with a 20% coinsurance after the deductible. Medicare Advantage plans may offer some additional benefits beyond original Medicare, such as personal care assistance or meal delivery. There may be some transportation services or in-home support, but it is really important to compare specific benefits of a Medicare Advantage plan because coverage is going to vary significantly by plan. And Medicaid offers the most extensive home care coverage, including personal care, homemaker services, and adult daycare. It does cover long-term custodial care that Medicare does not. The eligibility for Medicaid really is fairly strict. There are income and asset limits. It varies by state, but we'll talk more about Medicaid in a moment. Same here, I'm going to breeze through these a little bit. Medicare does not cover room and board for assisted living, which is the primary expense. They're going to potentially cover some skilled medical services if that's offered at the facility. Coverage for Medicaid varies by state. There are some states that offer coverage through a home and community-based services waiver program. But again, that is variable by your location. At an assisted living, you're going to be likely paying privately. So there is often not going to be any kind of coverage unless you have long-term care insurance. But again, we'll talk about that a little more in future. So Medicaid coverage is usually the only option that covers extended long-term nursing care. It requires meeting income and asset limits through spending down. So each state sets their limits and their thresholds, and often it requires using most of your personal savings before you will qualify. The annual average cost, we've kind of talked a little bit about this, of a nursing facility exceeds $100,000 in many areas. So it is very easy and quick to deplete your retirement savings. So it really just highlights the importance of long-term care planning and making sure that you have things in place. Coverage for memory care is a lot similar to assisted living. So private pay is going to be the most common method. And some states, again, have that Medicare waiver, Medicaid waiver program, home and community-based services, but that's going to be dependent on your state. Something else that I want to bring up is there might be benefits and additional support through a program called Aid in Attendance, which is for veterans. And it can provide I think for 2025, it's about $2,400 in assistance for eligible veterans or their surviving spouses. So there are service requirements, income limits, and you have to meet some requirements as far as what kind of help you need for ADLs. But that's a good route to kind of take to see if you yourself or a family member are a veteran. It's a good route to check that out. So Medicaid is the real payer for long-term care in America. It pays for about 60% of all nursing home care. But as I mentioned, qualifying for Medicaid means spending down your assets generally to about $2,000 in most states. And it's why advanced care planning is crucial. A lot of times I will hear people say, oh, well, we make too much money for Medicaid. But for long-term care, Medicaid works differently. So if someone needs nursing home care and their medical expenses exceed their income, they can qualify even if they have a higher income. It's called spending down. Just like Medicaid is dependent, on states, it's the same for long-term care. So your eligibility thresholds are going to differ significantly sometimes across states. But there's federal guidelines that underpin all of it. So asset limits are typically $2,000 to $3,000 for individuals, but again, some states do have higher limits. Certain assets are exempt. So your primary residence, one vehicle, and personal belongings you can still keep while trying to spend down Medicaid. And Medicaid will be looking at, during the application process, they look for financial transactions that are made in the last 5 years. So 60 months prior to your application. So if you've made any kind of asset transfers that are less than fair market value, that can really result in penalty periods. So some people think that they can just, transfer assets to a loved one or, a family member. But Medicaid reviews do look at that kind of thing when they're reviewing your assets, and they will place a penalty against you. So there's a penalty period. There's a calculation for that. But it is important to make sure you're doing that appropriately. And I recommend seeking or consulting with an elder law attorney if you think that you might need Medicaid, long-term care Medicaid, or might need that for a family member, because they really are going to know the ins and outs of your state and what's best kind of as far as your assets are concerned. If your loved one has long-term care insurance, it's time to dust off that policy and read it really carefully. These policies vary dramatically. Some cover only nursing home care, some have assisted living, some offer home care, some have inflation protection, others do not. So it's really important just to know what you have so that you can plan. It's really crucial. Traditional long-term care policies are going to offer dedicated coverage, but it's like a use it or lose it kind of structure. So if care isn't needed, then you kind of lose your premium. There are other hybrid type life insurance products that combine a death benefit with long-term care coverage, which is a nice option for kind of that middle income gap where families earn too much for Medicaid, but can't really easily afford traditional long-term care insurance because it can be quite pricey. Those kind of policies will offer lower premiums than like a standalone long-term care policy, and you still keep your asset protection. Switching gears a little bit to finding quality care for your loved ones. This process can feel quite daunting, but the good news is there are more tools available than ever before. just taking a look at some of the resources, Medicare.gov has a care compare tool that's like consumer reports for healthcare providers. So you can look up nursing homes, home health agencies, hospitals in your area, and see their star ratings, inspection results, and kind of compare and contrast. I really encourage you to go to the Medicare.gov website and look up facilities in your area. There's all kinds of really insightful information on there. They post staffing ratios, health inspection results. You can even look at how often they use antipsychotic medications. So there's really important information that you can find on the Medicare.gov Care Compare website. Also, your local area agency on aging is probably the most underutilized resource in America, in my opinion. These agencies exist in every community, and they know everything about local resources. They can tell you about transportation programs, meal delivery, respite care. They have social workers who can do home assessments. If you go to the elder care locator on the slide right now, you can enter your zip code and get the contact information for your local area agency on aging through there. SHIP is also a great resource for Medicare beneficiaries and their families. They offer counseling on choosing the best plan, understanding benefits. It's really a nice program and it's free. So I am just going to kind of go through these quickly. There are a lot of professionals that can help support, and it's important to kind of have your team help you make informed decisions, help you avoid making choices in a crisis. So the first is geriatric care managers. They can kind of be a professional advocate for you throughout the journey. They can provide care coordination services, really great. Hospital discharge planners, you know what these are. They just help facilitate safe transitions from hospital to home or another care setting. They're really great resource connectors and really can help connect and coordinate with medical teams to ensure that there's a good continuity of care. Social workers provide counseling, emotional support during what can be difficult transitions, and advocate for patients to access appropriate services. And I mentioned earlier, elder law attorneys are going to be a good resource, specialize in legal issues for older adults and their families, estate planning, powers of attorney, advance directives, Medicaid planning, asset protection strategies, and then if needed, can also address things like guardianship and conservatorship. If you do need to look into a long-term care facility for your loved one, I just want to touch on a couple things that you should be looking at to determine if it's a good fit. When you meet with the staff, ask about staff turnover rates. Good facilities will proudly tell you that their nurses and CNAs have been there for years. They love to boast about it. So that's something to really be aware of. Ask what happens if the care needs change. Do they provide more services or do you have to move? And then something else that's important to a lot of people is their philosophy on family involvement. Do they want you to be a partner in care or do they want you to just visit? So a couple of things just to think of. And same here, some kind of red flags to look at. If a facility will not let you visit unannounced, that is a red flag. If they can't or won't provide any references from current families, that is a red flag. If the staff seems frazzled, or if you see kind of the same job posting over and over for the facility, they're probably experiencing high turnover. And unfortunately, care and continuity of care can suffer when residents are constantly interacting with new, unfamiliar people. Moving on to advance directives and legal planning. This is a conversation that many families put off, but in my opinion, it's one of the most loving things that you can do for your family and for your loved ones. I'm just going to briefly go over these. The first essential document is a healthcare power of attorney, sometimes called a healthcare proxy. It lets a patient designate a trusted person to make medical decisions. It takes effect only when they are unable to communicate their own wishes. It should be someone who knows what values you have or your loved one has and can help advocate for those. It's more flexible than a living will because it allows you to respond to unexpected situations. A living will outlines treatment preferences and wishes for end-of-life care. There's specific circumstances for terminal illness, permanent unconsciousness, advanced dementias. And it covers preferences for things like life support, resuscitation, artificial nutrition. The POLST form, which you're probably familiar with, converts those wishes into actual medical orders that follow you across care settings. So a lot of people who have serious illness choose to go this route for kind of care planning, and it is sort of more immediate and specific in a lot of situations in a living will. And then a HIPAA authorization permits doctors to discuss medical information. You're well aware. These documents all work together to ensure that the healthcare wishes are known and legally enforceable when needed. Financial powers of attorney, it's important, allows you to designate somebody you trust to make financial decisions. A will and testament specifies how you want your assets distributed. Trust documents provide control over when and how those assets are distributed. And representative pay forms are important for Social Security or SSI. This person's able to receive and manage benefits on behalf of the beneficiary, and the representative has to be approved by the Social Security Administration. So when you have the conversation with your loved one and when you're planning for aging and end of life, it's so important to time it correctly and have the conversation during calm times, not during a medical crisis. And my advice really is to have these conversations in pieces, maybe talk about living arrangement preferences one week, medical preferences another week. It does not have to all happen in one sitting. But one of the most important things is to start having them early while your loved one is still cognitively able to have them. So having conversations where everybody can think clearly and participate fully in decisions is really important. The earlier you can start having the conversations allows your loved one to express their true wishes and their values, reduces stress and uncertainty. And these kinds of conversations are easier when they're not driven by fear or urgency. So again, not waiting for a crisis. That sometimes we feel rushed. We're not able to be thoughtful or research or ask questions because we're just keyed up. So try to start having these conversations early and revisiting these decisions as health changes. So, care needs and preferences evolve as conditions progress and change. So what made sense 6 months ago may not be the best option now. So it's important to not only make these plans, but also check back in on them and make sure that the plans that you made are still aligned with the current reality and what values you have now. So it's not only important to discuss the timing, but also what does your loved one want aging and end of life to look like? What values do they want to prioritize? What matters most in terms of quality of life versus length of life? What are their preferences for medical interventions? What is their preference for comfort care? Do spiritual or religious considerations guide their decisions? Where do they want to be? How do they want their assets taken care of? How do they want their family involved? Who's going to serve as the primary caregiver? These are all super important things to consider as you're making these plans. And there's a lot of tools that help make these conversations more comfortable. A couple I'll go over. The first being the Conversation Project. It's a structured conversation guide that has kind of frameworks that make these difficult conversations manageable. So they kind of break the conversation into steps, which a lot of people really like the Conversation Project. It's easy to use, as is 5 Wishes. It is a straightforward, legally valid document. It covers both medical and care preferences. It's really easy and straightforward to fill out. So it's nice because you can, if you're not really sure how to start having these conversations, you can use one of these tools to kind of get things rolling. And if so, some people want to include healthcare providers in the discussions, especially when you start looking at things like the Pulse form. It's just important to be clear when you're making your plans. And like we talked about, review and update everything regularly, because major life events or changes in a diagnosis can shift, priorities or values. So briefly going through some of the challenges that you may face along the way and how to handle them. The first is resisting care. So your loved one maybe doesn't feel like they need to move or doesn't want the care that you may feel is necessary. They might feel like they're losing their independence, or they might be worried about finances. So a strategy that will work there is to start with those quick conversations, small, non-threatening. Also services wise, like simple tasks like lawn care or a meal delivery service can kind of help build trust gradually versus, just coming in with a nurse or directly moving them to a nursing facility. Simple gradual changes are often helpful in these situations. And like we've talked about, just involving your loved one in the decision-making process is incredibly important. Help them focus on maintaining independence. So frame the help as a tool rather than, something that's going to take away their independence. So, you can have this help. It'll help you stay in your home longer, and you can continue doing what you love where you want to be. Safety concerns, address safety concerns without being alarming. So using I statements about your worry rather than kind of criticizing their abilities. And you can always consider a professional to come in, like a third-party evaluation, to provide an objective perspective. Second, if you're sharing the load of caregiving with somebody else, you are likely going to have disagreements. So there's going to be a different perception about what's needed. There could be distance, remote family members might have an outdated impression of, say, their parent's condition, and then question the decision of those that are closer to the situation. There might be financial disagreements. So it's nice to, sometimes bring someone in. There might be a mediator, a facilitator, whether that's a social worker or a clergy member, to help keep the conversations productive, because sometimes it's hard to stay objective when your loved one is involved and everybody just wants what they think is best. So sometimes it's nice to kind of get a professional involved to serve as a neutral party. So the third challenge that you may face, or that we all may face as we get older, is financial stress. So my advice to that is to apply for any and all available benefits. We talked about Medicaid, we've talked about veterans benefits. Really just don't leave money on the table. These programs exist to help, but a lot of times require work and proactive applications, exploring community resources like we talked about, the area agencies on aging. They really can help connect to local services or faith-based organizations, nonprofits, that kind of thing. So another challenge that may come up is coordinating and managing multiple providers. So I recommend a central medical file, one master file that has all the diagnoses, test results, specialist reports, medical histories. It's important to update after all major health events or medication changes. And it's a good idea to store them both physically and digitally. And something else that will help with family disagreements too is a shared calendar. So it's a really nice way to kind of keep everybody on track as far as appointments, medication schedules, care responsibilities, that kind of thing. So that's a great tip. The last is caregiver burnout, and it's hard to ask for help sometimes. Caregiving is really demanding work. And when you're constantly tired or struggling to get out of bed, it's hard to care for someone else. So as far as preventing or, trying to solve this, the best thing is to say yes to help. Saying yes to assistance is not weakness. Helping, getting help from or accepting help from others is important. And as far as getting help, it's important to be specific about what help you need. Not just say, oh, I need help. Or if somebody asks, oh, do you need help or what can I do? Be specific. Say, I need help going to the grocery store. Or can you sit with mom while I run to the eye doctor? Whatever it might be. If you need help with meals, be specific about what you're needing, because people do want to help, but often don't know how or what kind of help is needed. So if you kind of have an idea and are specific about what kind of needs others can kind of fill in for you, that is ideal. So being a caregiver means being an advocate. So you are the voice for your loved one, and this takes organization and skill. So like we talked about earlier, when there's a strong emotional connection, sometimes we can lose the ability to be objective. So I'm not going to spend a lot of time here because you all kind of should know, but keeping a health journal, documenting symptoms, treatments, and outcomes as far as care is concerned, saving copies of test results, prescriptions, tracking what works and what doesn't, just helps identify patterns over time and can be shared with providers. One thing that's really important too is bringing another person to important meetings. So when emotions are involved or when high stress situations happen, we sometimes miss details. So if you have somebody else that can be there and take notes, or to be a support, that can be very helpful. And again, no matter who you're dealing with, try to remain objective, be specific about your problems as well as your needs. You can request written summaries of important conversations, and it's important for you to follow up on your promises and commitments, but also hold other people accountable for promises or commitments that they've made to you. And as far as your advocacy skills, it's important to know your as a caregiver, you have right to information about care and treatment, about participating in care planning, filing complaints and appeals, and if you're unhappy with the care that your loved one is receiving, you have the freedom to choose or change your healthcare provider or their facility at any time. So just a few key takeaways as we wrap up. Start planning with your loved one before they need care. You have more options and more resources are available to you than you may think. You can use your advocacy skills and improve them all the time. It's okay to ask for help, whether that's professional help or personal help. And any kind of plan that you are making for long-term care should be flexible and should be regularly updated and reviewed. So really starting these conversations now are going to make a world of difference for your loved one and for you. So thank you again for your time today. If you have any questions, I think we have a couple more minutes to address those. And you can reach me if it's more personal or if you don't want to share with the group today. My email is emily.brown@patientadvocate.org. Or if you or someone you know you think may benefit from our case management services, they can be reached at 800-532-5274.
Emily, there is one question in the chat. That we have. It says for the list of documents discussed, the living will and such, once signed, do they ever expire and need to be revisited?
So as far as expiration, not really. So if there are multiple versions of things like the living will or advanced directives, they will always accept the most recent copy. But like I mentioned, it's super important, like you said, to revisit them. Care needs change, prognoses change, conditions change. So as that happens, it's a great idea to look at what plans were made and just kind of make sure that they still make sense. They still fit with the preferences and wishes of your loved one.
Emily, I have a question. I started out my medical career as a CNA, and that has come in so handy as I've helped to care for my parents and then later on my husband. And I just wonder if you're aware are there places that give CNA-like training to caregivers to help them to know like the best way to put on somebody's clothing when they have an injured limb, or how to safely give somebody, how to safely bathe somebody, that kind of thing. Because, it's just so much easier to be a caregiver if you feel like you know what you're doing.
Yeah, absolutely. I am not aware of any. That would be a fantastic resource. I can certainly take a look. And again, the Area Agency on Aging may be familiar. Or in that case, it might be good also to check with the patient's, if there's like an injury or anything. Like I know physical therapists will often come to do home assessments and to do a lot of teaching for patients in the home. So that might be a good option as well. Like when I was working at the nursing facility, we would often have our physical therapists or occupational therapists do home visits to check out the area and make recommendations for the family for what might be safest when they got home. So removing area rugs, installing grab bars, that kind of thing. So I would think that if that's a situation where someone's recovering from an injury or a surgery, that they could reach out to their therapy team to ask for some of those home recommendations, as well as things like you mentioned, moving someone or readjusting someone in the safest way.
Yeah, I think I worked with hospice was my final professional activity, and hospice does do a really good job of training family members how to do that. But I just wasn't aware of any other like resource for that.
Yeah.
The other thing I would say from just is that if people have any death cafes available in their area, that sounds like a really weird thing, but a death cafe is a chance to sit and have something to eat and drink with other people and talk about end of life or choices and decisions in a very comfortable kind of setting. So I would recommend that as a resource for people that are wanting some, I don't know, further education and a place to think about those things. But everything you said, I was a family physician, geriatrician, hospice doctor, and everything you said was so spot on. So I really, really appreciate your being with us. And I'm glad we have you on recording so that other people can use this resource.
Absolutely. Thank you.
Are there other questions? Well, really, really appreciate you, Emily.
Certainly. Thanks for having me.
Yeah. And for the other people on the call, next chapter, we'll be having more webinars, and we've also had some luncheons. Our most recent one was in Roanoke, and we've had them in Northern Virginia and Hampton. And in 2026, we'll have more activities. There is a web page for the next chapter on the MSV as a subset of MSV's website. So please, look at that for further information. And thanks everyone who attended, and also to our speaker.